Welcome to The Deep Dive. We're the place that cuts through the noise, stacks up the sources, and gives you that core knowledge you really need. Today, we are diving into something you see all the time in clinical practice. The antibiotic Piperacillin-Tazobactam. Most people call it PipTaz. And specifically how we use it best against a really tough bug, Pseudomonas aeruginosa. Now, for years, whether it's hospital-acquired pneumonia, maybe serious sepsis, the go-to for heavy-duty Pseudomonas coverage seems to be this high-dose regimen, 4.5 grams IV every 6 hours.
That's right, that 4.5 G IV Q6H. And just quickly, that Q6H, for anyone listening, just means every 6 hours. Standard timing for a lot of antibiotics.
Exactly. So the core question for our deep dive today, looking at the evidence, is that standard high dose, that 4.5 grams Q6H. Is it really the optimal choice or, even always necessary for Pseudomonas?
Well, based on the predictive modeling, the source material we looked at, the short answer is actually pretty surprising. It's no.
No, straight up.
Straight up, it's not always needed. And in some really key situations we'll get into, it's often not even the best approach. If you look at the Monte Carlo simulations, those are the computer models, predicting how likely a dose is to work that high dose, given quickly, doesn't consistently hit the goal we aim for. That's the 90% probability of target attainment, or PTA.
Okay, so there's a disconnect. We have this common practice, this default high dose, but the modeling designed to predict success, it doesn't consistently back it up. So our mission today is to get past just the total amount of drug, the dose number, and really understand the pharmacokinetic factors that actually drive how well PipTaz works. What really matters more than just quantity.
Right. And to get that, you have to grasp this fundamental concept for this type of antibiotic. It really boils down to duration. The key metric is something called FTMIC.
Okay, FTMIC. Sounds a bit like technical jargon, maybe something to trip you up when you're making a quick decision. Can you break that down? Why is that the number one thing?
Yeah, it sounds technical, but it's straightforward conceptually. It stands for fractional time above the minimum inhibitory concentration. See, for antibiotics like PipTaz that work over time, they're time-dependent, the key isn't hitting some super high peak level. It's about how long the drug concentration stays above the minimum level needed to stop the bacteria growing. That minimum level is the MIC.
Ah, okay, so duration above that minimum threshold.
Exactly. Think of it like maybe watering a plant in really dry soil. You could dump a huge bucket on it all at once. That's like a high peak dose, but most just runs off.
Yeah, makes sense.
Or you could use a slow drip, maybe over a few hours. That keeps the soil consistently moist for longer. That's what PipTaz needs against the bacteria. Continuous saturation above that MIC.
That's a great analogy. Really clears it up. So duration, not just the big splash. And what duration are we shooting for? What's the target?
The sources consistently point to this, hitting 50% TMIC. So keeping the drug level above the MIC for at least half of the time between doses. That's linked to better outcomes, especially for sick patients with aeruginosa.
Wow.
And that PTA we mentioned, the probability of target attainment, that's just our statistical confidence, really, that a specific dosing plan, the amount and the timing will actually achieve that 50% TMIC target. We aim for 90% confidence or 90% PTA.
Which means the MIC of the specific bug you're treating becomes absolutely crucial, doesn't it?
Totally. It's the whole hinge point.
If the bacteria is more resistant, its MIC is higher, so the bar for the drug concentration is higher. And we saw some data, I think from British Columbia and Canada was the example, suggesting that maybe 80% of Pseudomonas strains have a fairly low MIC, like less than or equal to 8 milligrams per liter.
Exactly right. And knowing your local data, your local resistance patterns, that's really where you have to start. So let's tackle that majority first. Those bugs with the lower MICs of 8 or less, what the analysis shows pretty clearly is that for those infections, the standard dose, that's the 3.375 grams IV Q6H, it works. It achieves that goal, that 90% PTA for 50% FTMIC.
So the standard dose works fine for most cases?
Yes. The clinical takeaway here is really important. For the majority of infections where the bug isn't highly resistant, the standard 3.375 G dose is effective, going straight to the 4.5 G high dose. Statistically, it looks like unnecessary overkill.
Okay, let me push back a bit here, though. If 3.375 micrograms every 6 hours works for, say, 80% of these cases, why do so many places seem to default immediately to the 4.5 gram dose? Is it just easier to order or a better safe than sorry feeling? Inertia?
I think it's probably a mix of all those things. Definitely inertia. This is how we've always done it. And there's a strong safety mentality, especially with serious infections. Clinicians often feel, safer giving more drug, especially when someone's really sick, even if the underlying PK/PD science doesn't necessarily support just giving a bigger dose faster. We're often trained to be aggressive err on the side of more.
I get that instinct, but like you said, the higher dose costs more, maybe adds risk of side effects, and it's not needed for most bugs. Okay, but let's shift gears. What about the really resistant ones, the tough cases? What happens when the MIC is high, say 16 milligrams per liter or even higher?
Yeah, this is where the traditional approach, the short infusion strategy, it completely breaks down. It's actually quite shocking when you look at the models.
Breaks down how?
The data shows that neither dose, not the standard 3.375 GIV Q6H given over 30 minutes, nor the high dose 4.5 GIV Q6H over 30 minutes, neither one achieves that necessary 90% PTA goal when the MIC is 16 or higher.
Wait, hang on. Even the high dose, the 4.5 grams, fails if the MIC is 16.
If it's given as a short 30-minute infusion, yes, it fails to reliably meet the target.
Wow, that is really critical. So we're potentially using this higher, more expensive dose, thinking it's our big gun for resistant bugs.
Exactly.
And it's still missing the mark against the very infections we're most concerned about. What's the risk there, clinically, just relying on that failing strategy?
Well, the immediate risk is underdosing, essentially, subtherapeutic exposure.
Right.
And that can lead straight to treatment failure, longer hospital stays.
More costs, worse outcomes.
Right. And it also ramps up the pressure for even more resistance to develop. Giving a bigger dose quickly just doesn't increase the time the drug stays above that higher MIC threshold enough. It becomes almost an exercise in futility for those resistant strains.
And just quickly, that 4.5G Q6H dose became common partly because the FDA looked at it, right? What was the basis for that?
They did review it, yes. But the original evidence for 4.5G IV Q6H mainly showed it wasn't worse than another antibiotic, imipenem. It showed similar hospital days, readmissions, side effects. So it proved it was kind of as good as imipenem, but that study didn't necessarily prove it was superior as a dosing strategy compared to the standard 3.375V dose, especially in terms of hitting these crucial PK/PD targets we're talking about.
Got it. So, okay. We've established the high dose often fails against high resistance, and the standard dose only works for low resistance. That leaves a pretty big gap, right? How do we successfully treat those high MIC bugs, the MIC16s, if just upping the dose quickly doesn't work?
So the single biggest solution, the thing that comes up again and again in the source material, is changing how we give the drug. It's using extended infusions.
Extended infusions, meaning dripping it in over a longer time.
Exactly. This is how you directly manipulate that critical factor, the FTMIC. By stretching out the infusion time, say from 30 minutes to 3 or 4 hours, you keep the drug concentration above that high MIC level for a much longer portion of the dosing interval.
Okay, that makes perfect sense based on the FTMIC principle.
Yeah.
But practically, switching to a 3 or 4 hour infusion, that ties up an IV pump longer, right? Needs more nursing attention, might clash with other meds. Isn't that practical friction maybe why hospitals stick with the quick infusion, even if it's not ideal pharmacologically?
Oh, absolutely. That friction is real. It's probably the biggest barrier to adopting extended infusions more widely. It takes changes in workflow, pharmacy needs to be on board, nursing needs the resources, pump availability, scheduling. It's a logistical challenge.
Yeah, I can see that.
But you have to weigh that against the alternative. If the short infusion leads to treatment failure, needing to switch to maybe more toxic or way more expensive backup antibiotics, then suddenly figure out the logistics for extended infusion seems like a challenge worth tackling, doesn't it? Optimal care sometimes means we have to solve the logistics. And when you do make that shift, the results, according to the models, are dramatic. For those high-resistance bugs, MIC16 specific extended infusion regimens do achieve over 90% PTA.
Okay, which ones work?
The data supports giving the 4.5 grams Q6H, but infused over 3 hours. Or even a slightly less frequent dose, 4.5 grams Q8H, that's every 8 hours, but infused over 4 hours. That slow drip ensures you hit the target where the short burst completely failed.
So the message is clear. When resistance is high, extending the time is the crucial intervention, not just increasing the dose amount given quickly. And this isn't just theoretical modeling, right? There's clinical literature backing this up.
Yeah, for those listeners who like to read the papers, a study by Gill and Nicolau in 2023 confirmed this exact pattern. They found 3.375G Q6H over 30 minutes was fine for MIC8. But
But you needed 4.5G Q6H over 3 hours, or that 4.5J Q8H over 4 hours, to reliably get above 90% PTA for the MIC16 bugs. And there was another study, Thabit et al., from 2017, that strongly reinforced this. They explicitly found both short infusions, the standard and the high dose over 30 minutes, fail to hit optimal PTA at MIC16.
So the consensus seems pretty solid then. High MIC needs longer infusion. It's practically mandatory, not just a nice idea.
That's how the PK/PD science point, yes. Okay, let's just circle back for a second to general practice. We did see some clinical data, like from Lorente back in 2009, that sometimes showed the actual clinical cure rates between 3.375G Q6H and 4.5G Q6H given short. Well, they were often pretty similar. Sometimes no significant difference was found. That seems to add more weight to the idea that defaulting to the higher dose quickly doesn't always buy you much extra clinically, at least in some average scenarios.
That's a fair point, and it balances the picture. But we absolutely have to add a really critical caveat here, especially for listeners working in very complex settings like the ICU.
Okay, what's the caveat?
It's crucial to remember that these Monte Carlo simulations, the models giving us these baseline rules, they're based on typical parameters. They generally did not include specific, highly complex patient groups,
Like who?
like critically ill ICU patients who might have fluid shifts or organ dysfunction, or patients with significant obesity or severe burns or cystic fibrosis or even large amounts of abdominal fluid ascites.
And why do those groups make such a difference? How do they change the rules?
Because those conditions can drastically mess with how the body handles the drug, the pharmacokinetics. Someone with burns or CF might clear the drug much, much faster than average. They might actually need a higher total dose or more frequent doses just to keep the level up.
Ah, okay, faster elimination.
Right, or someone with obesity or massive ascites, they have a huge volume of distribution. The drug spreads out more, gets diluted, so the concentration might drop too low too fast. So the standard rules from the simulations, even the extended infusion rules, might not perfectly apply to these really complex patients.
So what do you do then?
Well, for these patients, the models give us a starting point, but you might need to adjust further. And often, this is where therapeutic drug monitoring, or TDM, comes in, actually measuring the drug level in the patient's blood to make sure you're hitting the target concentration.
Right. Personalizing the dose based on the individual's physiology?
Exactly. The simulation gives a general principle, but complex reality needs that personalized touch.
Absolutely. The basic rule is time over quantity, but applying that rule wisely is where the real clinical skill lies. Okay, let's try and boil this all down. Let's condense everything into maybe 3 key takeaways you can use right away. First, that standard dose, PTZ 3.375G IVQ6H, it's generally effective and hits the target for lower resistance. Pseudomonas strains those with an MIC less than or equal to 8 milligel. If you're automatically jumping to 4.5 grams for these, the data suggests you might be using more drug, more resources without a clear benefit. Second, and this one is probably the most critical, for highly resistant strains, MICs of 16 milligel or more, neither the standard short infusion nor the high-dose short infusion works reliably. Giving piptads over just 30 minutes against these bugs is very likely setting you up for suboptimal treatment. And third, to actually beat those high MIC infections, extended infusions are essential. Something like 4.5G Q6H dripped in over 3 hours, or 4.5G Q8H over 4 hours, that's how you achieve the needed PTA. Success comes from optimizing the time the drug is active, not just maximizing the initial dose amount.
Which brings us nicely to our final thought to leave you with. Given all this data showing that fundamentally more drug doesn't equal better when given quickly, and realizing that maximizing time is the real goal, we really have to ask, how does really understanding these PK/PD principles challenge our ingrained, maybe default dosing habits? You know, the ones based on just picking a dose number. And maybe more broadly, what are the implications for antibiotic stewardship, for resource use, if we all started truly optimizing for time rather just quantity? It's a challenge, really, to make sure we're dosing smarter, fighting resistance with precision, not just brute force volume. Something to think about.